3D classification with us. Just a few introductory points. We all know Professor Lenke. Professor Lenke is the chief of spinal deformity and professor of orthopedic surgery in neurological surgery at the Columbia University. He is the co-director of Oxspine and surgery-in-chief of the Oxspine Hospital at New York Presbyterian Allen Hospital. He also was the past president of the Scoliosis Society. He is the co-chair of the Scoliosis Society 3D Task Force on 3D classification of adolescent idiopathic scoliosis. Apart from clinical work, he enjoys many outdoor activities and spending time with his wife Beth and married children and grandson. I would also like to invite Professor Newton. Professor Newton, I had privilege and honor to spend some time and learn directly from him at San Diego, California. He's the chief of orthopedic surgery at Rady Children's Hospitals in California, USA. He was the president of the POSNA as well as the Scoliosis Society. In addition to his clinical practice, Dr. Newton enjoys traveling, fishing, and subjects of auto mechanics. We are also honored to have Dr. Carlo Aubin, a professor of biomechanical engineering at Polytechnique Montreal and at the University of Montreal. He is a researcher and special advisor on innovation at the Saint Justine University of Hospital Center. He is the chief executive and scientific officer of the Montreal Transmed Tech Institute. He is a co-chair of the SRS 3D Task Force on AIS 3D classification. His distinctions include being named an officer of the Order of Canada and of the Ordre National du Quebec. He enjoys outdoor activities such as sailing, biking, skiing, and cherishes time with his wife, Mary France, and their children, both pursuing doctoral studies. We are also honored to have extreme panelists, including Dr. Carlo Iorio from Italy, Dr. Theresa Pazionis from USA, Dr. Josephine Coury from USA, and Dr. Piyush Gadegone from India. I like to involve all the speakers and all the panelists. I also like to invite all the guests, the viewers, for their active participation. All over to you, Professor Newton. Professor Lenke.
Great. We all set, Raj? Can you see my slides, Raj?
Yes, I can see Professor Newton.
Great. Thank you. All right. Well, thanks so much for setting this up. I really appreciate it. You know, it's an honor to promote our new 3D classification system that, again, emanated from the SRS 3D classification task force that's co-chaired by Carlo Aubin and myself. I want to acknowledge our task force members here as well. I won't list all their names, but they're listed here at the bottom, including Professor Newton that we're all aware of. So our disclosures that are really not applicable to this concept or talk, but you know, we all know that we've been living in 2D for the communication, classification, and treatment of scoliosis for quite some time now. And we have to kind of move beyond that. But for many years, and really the last 25 years, we've been able to classify and communicate on the curve types and patterns through this 2D system that we were able to publish in JVJS in 2001. Again, this was really came from the Harms study group and worked with myself and Randy Betts and Jürgen Harms, Keith Bridwell, and others. We came up with this three-tiered system, one of six curve types based on whether the proximal thoracic, main thoracic, or thoracolumbar region was the major curve, which was the largest curve, and whether the other two regions were either minor structural or non-structural curves that depicted then the one of six curve types. And then we had two modifiers. The lumbar spine modifier was basically detailing the deviation of the apex of the lumbar curve from the center sacral vertical line, A, B, or C. And then a thoracic sagittal profile modifier, hypokyphotic, normal kyphotic, or hyperkyphotic based on the T5 to T12 sagittal cob. So this became the gold standard for classification and did have obviously treatment recommendations that we were trying to emphasize treatment of the major curve and the structural minor curves and to not treat and fuse the non-structural minor curves. And this today is still the 2D gold standard. But anyone who practices scoliosis, either seeing patients or doing surgery, understands that scoliosis really is a three-dimensional problem, and we really are short-sighted in only classifying and treating idiopathic scoliosis in a two-dimensional perspective. So we really need to kind of understand the third dimension, which is much more harder to kind of visualize and depict these transverse kind of plane rotation and regional plane malalignments that are inherent to the three-dimensional transverse plane deformity as part of idiopathic scoliosis. So, and really, when you look at the transverse plane, there's kind of global curve deviations and torsions, and then individual vertebral rotations and tilts that need to be depicted. And so, in creating this new 3D based system, we wanted to acknowledge and be able to decipher the regional and local vertebral transverse plane deformities that are inherent to scoliosis. And I think that's what we've tried to accomplish in this new classification system. So, along the way, we wanted to make sure that when we developed this system, that it was clinically relevant, trying to make it very clear and ambiguous, with have objective criteria to separate out the various transverse plane modifiers. We've had to overcome technological barriers, and I think Eric will talk about that to make sure that anyone obtaining biplanar X-rays can still obtain these 3D transverse plane modifiers and to allow us to classify curves in 3D, and also then be pragmatic. If we try to create, and we discussed this, try to create an entire new system of 3D classification, that might be a little too much for everyone to kind of decipher and agree upon. So what we decided as a group in the 3D task force was to build upon the established 2D system and then add these 3D transverse plane modifiers to the 2D system instead of coming up with an entire new system. And hopefully that will kind of ease the transition from 2D to 3D in those who are going to want to use this system. So again, the new SRS Lenke Aubin 3D classification of AIS really begins again with the 2D components. So we'll keep the curve type 1 through 6, the lumbar spine modifier A, B, or C, and then the thoracic sagittal profile modifier minus, N, or plus. So we're going to keep those components, and we're going to add two new transverse plane modifiers. The first will be the orientation of the regional planes of deformity, abbreviated ORPD, and you see it's a three-tiered modifier, 1, 2, or 3, based on, again, the degrees of this orientation of regional plane deformity. And then we're going to depict this in all three regions: the proximal thoracic P, which will be in blue, the green will be thoracic, main thoracic, and then the thoracolumbar lumbar will be in orange. So all three of these will be obtain one of these transverse plane modifiers, 1, 2, or 3. And then for the local vertebral modifiers at the apex, we have the AVR, the apical vertebral rotation modifier, which again will be SML, small, medium, large. Again, depicted for each of the proximal thoracic, main thoracic, and thoracolumbar lumbar curves. So that's how we're going to basically describe this. So we have the curve type plus lumbar spine modifier plus thoracic sagittal modifier, and we add these two new transverse plane modifiers for the PT and L segments for ORPD and AVR. So an example of a new SRS Lenke Aubin classification system could be 1BN, which is again the traditional 2D classification, and then we add P1M, T2M, L2S would be again a potential classification, adding these transverse plane modifiers. So again, that just introduces again how we kind of added on to the existing 2D system to make this new 3D system. And at this point, I think I'm going to stop sharing my slides, and Professor Aubin is going to further define for us, I think, these transverse plane modifiers, which again was really kind of his brainchild, especially the ORPD and how we're going to depict the regional plane modifier of the transverse plane. So, Eric, you want to take it from there for a bit, if you don't mind?
Sure, thank you. Do you see my screen?
Yes.
Okay, so hello everyone. First, I would like to thank you, Dr. Raj Sakhrekar, for the invitation and for the opportunity to share our work on the new 3D classification of AIS. And I think Dr. Lenke has introduced the rationale and the concepts. the complexity of the spine as being three-dimensional needs tools to be able to describe them. And as Dr. Lenke mentioned, the goal of our 3D task force was not to replace, but make the existing Lenke classification evolve by adding a limited number of carefully selected 3D descriptors. As mentioned by Dr. Lenke, we need to balance between the granularity, the precision, the usability, and clinical relevance. So therefore, we have introduced those two descriptors, one at the describing the regional deviation or deformity, and the other one more at the local vertebral level, which describe the torsion of the rotation of each vertebra. So let me give you a quick tour of the new descriptors, beginning with the regional characterization of the deformity. So first, we start with the 3D reconstruction, which can be obtained with any radiographic systems, not only by planar low-dose system, but on all other systems. The technology we develop enable to do this 3D coordinate reconstruction. So following the 3D reconstruction of the spine, the process extracts the 3D coordinates of key vertebra, so the centroids of the end vertebrae and the apical vertebra of each region, as defined by the Lenke method. And then they are projected on the transverse top view plane. Then these 3 points per region are connected to define triangles. So triangles connect the end vertebrae and the apex, which defines what we call the regional planes of deformity, or RPDs, for the proximal thoracic, the main thoracic, and the thoracolumbar region. It reflects the spatial position and orientation of each region of the deformity. So zooming in, here are those RPDs again. To make them easier to visualize, we extended the triangular planes by twice the distance between the apex and end vertebral line, keeping same orientation and assigning color. Again, blue for PT, green for MT, and orange for thoracolumbar lumbar. So the orientation of each regional plane relative to the sagittal plane defines the regional transverse plane modifier, which we called ORPD, for the orientation of the regional planes of deformity. Conceptually, in an asymptomatic spine, the main curves lie close to the sagittal plane when viewed from the top. With scoliosis, these curves progressively evolve with the initiation of a coronal curve and the modification of the sagittal curvatures, resulting in a shift and change in the orientation of the regional planes of deformity with respect to the sagittal plane, the original sagittal plane. So the ORPD captures not only the lateralization of the curvature, but also how the sagittal plane is evolving. So this complements the traditional coronal and sagittal measures. This slide shows example. First, a non-scoliotic spine with curves aligned in the sagittal plane. So you can see that the ORPDs are very close to zero. Then a mild scoliosis with early lateralization of the planes. And in more severe cases, this shift is greater laterally, but also the angle change as the sagittal plane is changed. And often there is a flattening of the sagittal curves, which can be captured by this angle. And sometimes even leading to a thoracic curve that becomes lordotic. So in this way, then the RPD is greater than 90 degrees because the apex is anterior to the end vertebrae. So the RPD concepts helps characterize these evolution. This other animation here shows all these planes should ideally be corrected, not merely shifting the curve laterally, but curvy linearly realigning to restore their natural anatomical orientation and spatial coherence. Now let's turn to the descriptors that characterize the transverse plane at the local vertebral level. So in the transverse plane, at each vertebral level, we can identify the rotation of each vertebra relative to the asymptomatic sagittal axis. Here, this is represented by arrows, whose length is proportional to the magnitude of rotation, allowing us to visually appreciate the relative intensity of the rotation. As with RPD, we use the same color coding, blue for proximal thoracic, green for main thoracic, and orange for thoracolumbar. Okay, since the maximum rotation typically occurs near the apex of the curve, we chose to retain only the apical vertebral rotation with respect to the sagittal plane. This allows to reduce the number of variables that we have to carry while still capturing the essence of local torsion. Together, as Dr. Lenke mentioned, these regional and local transverse plane modifiers are integrated into the existing Lenke classification to build the new SRS Lenke Aubin 3D classification. So the three first are the curve type, the lumbar spine modifier, and the thoracic sagittal profile modifier. And then we are adding for each anatomical region, proximal thoracic, main thoracic, and thoracolumbar, a number and the letter to describe the orientation of regional planes of deformity and the apical vertebral rotation. And so it's 1, 2, 3 or SML with 2 thresholds per descriptors. And when adding the letters, the numbers and the letters for each of the proximal thoracic and main thoracolumbar region, it's simply the addition. It completes the existing Lenke classification by adding these other modifiers. I will just now give some reason why we selected the thresholds level. So for the transverse plane regional modifier, so for the ORPD, we established the 3 subclasses, 1, 2, 3, based on angular thresholds of 70 and 90 degree that were derived from extensive case simulation analysis where we tested various Cobb, angle, and thoracic kyphosis and ORPDs. And basically in subclass 1 with an ORPD smaller than 70, the main thoracic curve usually retains a thoracic kyphosis greater than 20 degree, indicating a preserved kyphotic profile. In subclass 2, between 70 and 90 degree, these are intermediate case. So there's a lateralization of the curve, often coming with changes in the sagittal components and a thoracic kyphosis often less than 20 degrees, suggesting a flattening, sagittal flattening, which can be captured by this orientation, greater orientation. And with subclass 3, when the RPD is greater than 90 degree, then the apex is anterior to the end vertebral line, here for the main thoracic region, indicating a curvature reversal and a marked transverse deformity. So we have used the same logics and same analysis for the thoracolumbar lumbar curve and proximal thoracic with similar rationale to establish the numbers. Now for the local modifier, AVR, we define 3 subclasses, S for small, M for medium, and L for large. When it's smaller than 10 degree, it's a small apical vertebral rotation. The vertebra orientation remains close to the sagittal plane. When it's between 10 and 20, it's becoming moderate. This contributes to curve rigidity. And when it's greater than 20, it's a marked AVR, indicating structural torsional deformity, which will require more derotation technique to restore the alignment of or detorsion of the spine. So finally, again, here is an example showing the step by step how the new 3D classification is assembled. First, the curve type. Here it's a 1, it's a main thoracic curve. It's a B for the lumbar modifier. And then for the thoracic, it's N, normal. And then we are adding the modifiers for the ORPD because it's between, it's 53 for the proximal curve, so it's lower than 70, so it's a P1. Between 70 and 90 for the thoracic, so it's a T2. Same for lumbar, L2. And then for the And then we are combining that with letters for the apical vertebral rotation, or AVR. So for the proximal thoracic, 11 means medium. Same for the main thoracic curve, M, and S for the lumbar curve. So when we combine the views, it's quite easy. We look at the proximal thoracic region first, then the main thoracic, and then the lumbar. And we combine the number and the letters for describing the regional plus the local descriptors of the transverse plane. So P1M, T2M, L2S, which are added to the existing Lenke system. So we can still use the Lenke classification, 1BN, and then add the other modifiers to additionally describe the transverse plane. So I will stop here, just saying that we have 2 publications now on this. The first one was published in December. This is how you can have access to this. And the other was published last week. And we also have a one-pager enabling members of the SRS to look at the descriptors and try to learn them from this. So with this in mind, I will stop from here, and thank you very much again. And Larry, I will let you continue.
Great. If you can stop sharing, I'll finish up. Carlo, thank you. It was an excellent summary of the new transverse plane modifiers. Let's see. All right. Can you see my screen again?
Yeah, we can see it, Professor. Yeah.
Great. So so what I like to do is just kind of highlight how these new transverse plane modifiers, number one, kind of depict what would look like similar kind of 2D curve types, really in a much more different manner when we highlight the 3D modifiers. And also emphasize that these 2 new transverse plane modifiers, ORPD and AVR, are really complementary. They're not tied in such that if you have a larger ORPD, you must have a larger AVR. They're really independent, and we've actually studied that as well. So they really are. It's really necessary to have both the regional plane ORPD transverse plane modifier and the local vertebral AVR to truly assess what's happening kind of transverse plane at the apex of the PT, MT, and TLL curves. So if you look here at these 2 curves at face value, they're both 61-degree main thoracic curves. They're both type 1 curves. Obviously, the one on the left is a B modifier, one on the right is an A modifier, and the one on the left is a hypokyphotic sagittal modifier, one on the right is N normal kyphotic. But again, if we look specifically at the thoracic curve, ORPDs and AVRs, the one on the left really has a much more severe ORPD at 98 degrees. So again, as Eric mentioned, the apical ORPD is really inverse, such that the thoracic kyphosis is really in now true lordosis at 98 degrees. So it's a T3 ORPD modifier. The one on the right is 76 degrees. So although it is obviously mal-oriented in this kyphotic sagittal plane, it's not nearly as mal-aligned as the one on the left. So this gets a T2 modifier at 76 degrees. But if you look at the AVR, the rotation modifiers, even though the one on the left, again, is regionally very mal-aligned, and the ORPD, there's a small AVR, only 4 degrees. So it's a T3S for the AVR, when the one on the right is a much larger AVR at 23 degrees, so that's a larger 2TL transverse plane modifier. So that's, again, just showing that the ORPD and AVR transverse plane modifiers are truly complementary and can be quite distinct and different based on, again, the 3D components of the deformity. The same thing in the lumbar spine. On the left, we have an L2M for the thoracolumbar ORPD and AVR. On the right is L1S. So again, these are different as well. Much larger ORPD and AVR on the left case, and on the right is much smaller at L1S. And then, but similar P1Ss for the proximal thoracic curve, a very smaller ORPD and AVR for both. So again, it's putting these together, although both 61 degrees, they're quite different in their transverse plane depictors, especially in the thoracic and lumbar regions for both of these curves. So again, hopefully we've in the last kind of half hour or so highlighted the two main points. Number one, that we just basically added on two new transverse plane modifiers to the existing 2D system to create this new SRS Lenke Aubin 3D classification of AIS. And number two, to really highlight how where these kind of ORPD and AVR modifiers came from, especially the ORPD. It does take a little bit of time, I think, to truly understand the rationale behind these, how we kind of came up with this, the triangles that are created, and again the goal of normalization of these ORPDs into the more normal sagittal profile, right? For all three of these regions, proximal thoracic, main thoracic, and lumbar, and then again the torsional or rotational components of the apex of the AVR. We're trying to derotate those components into a more mid-sagittal rotational alignment as well with correction of the scoliosis curve. So here's this one pager again, and the QR code is Carl mentioned. And I think at this time we're happy to answer any questions the group may have regarding this new 3D system. So thank you for your attention. And again, we're really proud of our work with the SRS and this task force. Want to again acknowledge the task force members for helping us create this new system that we think is going to revolutionize the way we classify, communicate, and then treat idiopathic scoliosis going forward. So thank you for your attention.
Thank you so much, Professor Lenke and Professor Aubin. There are a few questions. I'll start with the first one. We always knew the scoliosis is 3D deformity. Like first classification came back in 1905 by Ashok et al. And then the comprehensive 2D classification came by you back in 2002 in JBJS. And now after a few decades, we have 3D classification. When we asked few people around, I presented the slides shared by Professor Aubin to a few online presentations and everywhere. People getting used to it, but still a lot of people are confused because there are many subtypes to it, like more than hundreds, and people are getting used to it. So do you think how much time it will take for people to understand it more and more and get used to it?
Well, why don't I take that color as a clinician, if you don't mind, as a surgeon?
Yeah, go ahead.
Like anything, I think it is going to take time. I think one has to really study some of the videos that Carl Eric showed, how, again, the spine with scoliosis initiation and progression, how this ORPD really kind of shifts out of the mid-sagittal plane for especially if you focus on the thoracic curve. That's how I basically understood this. I really focused just on one region at a time. So pick the thoracic region to start with. Honestly, I think that to me, at least conceptually and visually, that was the easiest one to understand. And then the next one to go is the lumbar region, and last is proximal thoracic. That's a little bit more, especially ORPD, a little bit more difficult to comprehend. But look at the videos of the creation and progression of scoliosis and the ORPD, and then also the correction. I think, Carl, we really need to promote those videos. I really think if you understand the videos, you'll understand how the ORPD was created, and again, how we're really trying to classify and then treat that regional plane of transverse plane deformity. I hope the AVR is a little more straightforward. The AVR Errol Dawborn has been around, the classification of that for many, many decades now, and how the apex is torsionally rotated off the mid-sagittal plane, I think is at least to me and as a surgeon conceptually a little bit easier to understand. But I think, again, just separate out the thoracic from the lumbar, from the proximal thoracic when you are kind of analyzing these, and I think it'll be much easier to digest and understand. And then, we've made it simple. We don't have 10 different types of these. There's 3 types, right? 1, 2, or 3 for the ORPD and SML for the AVR. So we tried to simplify this a bit from the perspective. But I think the understanding, especially of the ORPD, is going to be the key component to this. Once you understand the ORPD, I think a light bulb is going to go out. And honestly, it took me several years to truly understand this. But also, I think if you're a surgeon, try and coordinate and correlate what you're seeing on the ORPD classification wise with what you're seeing in the OR. In your patient when they're open and you're trying to, basically correct scoliosis. I think that also was very helpful to me, that kind of top-down view of the 3D deformation of the main thoracic curve and how I saw that in the OR and how I was trying to recreate then a better mid-sagittal profile kyphotic apex, which is, is very difficult to do surgically. And I think if you correlate what you're seeing, what you're classifying pre-op, what you're seeing intra-op, both if you expose the scoliosis and all as you're trying to correct it, I think that will also help you understand the ORPD and the AVR concept, right? Because they're different. You can recreate more kyphosis, but if you don't untwist the apex, right, you're not going to get optimal 3D correction. So at least that from a clinician's perspective, that's how I've approached it. Carlo, what from a research perspective, anything to add?
From my research perspective, we need to say that first, scoliosis is complex. So there are many degrees of freedom, many bones that have a special position in space. So their torsion is complex. So really with this classification, we try to simplify and simplify and simplify to come out with two descriptors, one local, one regional. And I think these are the essential components. And of course, we can complexify that later. But for now, as Dr. Lenke mentioned, these are key aspects that are related to correction techniques. So derotation, so direct vertebral rotation, or more spatial reorientation of the spine when doing the correction. So I think we acknowledge it's complex, but we really try to make it simple by reducing the number of variables. So there are 2 variables per region. So I think it's the minimum we can have to describe a very complex system. The other thing, we also wanted to make it implementable. That means that we develop a technology which enables to be able to include any X-ray systems with taking into account the fact that there could be errors or inaccuracies when measuring and when doing this. The other thing was also to create a system that could be automated, so to facilitate the access. I think these were barriers which explain why in the past those were there, they were accessible but not used because it was difficult to have access and also to communicate. So I think when we designed the study, when we developed we tried to take into account all of this, and we came out with something which is a compromise between something which is granular enough to be able to describe the essential components of the deformity and having a relation with surgical strategies to do the correction. So this was, and I think Dr. Lenke mentioned it, and also something that could be maybe complexified later if we want to add more. But I think we need to learn. We need to our responsibility to educate, communicate, create animations, and create. And today this live the presentation enables to further disseminate this information, and we appreciate having the opportunity to do this.
I will ask questions from Dr. Carlo Iorio from Italy, and then I'll add later Dr. Piyush Gadegone, and then I will come with the questions from the audience. Carlo, do you have questions for Professor Lenke and Professor Aubin?
Yeah, sure. Thanks, Raj. Hi, Dr. Lenke, Dr. Aubin. It's Carlo Iorio from Rome, Italy. Thank you for your talk. And it's really a big effort, and I think it's hard. It will be hard to make it more simple than you did, because it's a very complex matter, and we know that when we treat surgical deformities in like scoliosis, it's a very complex matter, and it's really the 3-dimensional understanding of this. It's very important. So thank you again. My question is, for the surgical implication for this, does it this new classification is just to better understand the deformity, and in which way it will lead the surgical decision making? Just, for example, to put some strategies in for 3D restoration techniques. Let's say if we have like ORPD 2, 3, it's better to do some, let's say, pontes as opposed to just simple facetectomies when we have like RPD1, and if we have a AVR large, it's better to do a direct vertebral derotation as opposed to just a differential rod contouring in AVR small, something like this.
Yeah, I can answer. I can take a first stab at that. That's the obviously implication of this, that based on the degree of ORPD deformation from normal, that as the ORPD gets more negative, more minus from 2 to 3, that we should spend more of our efforts to release the back of the spine, or maybe go to the front of the spine, as Professor Newton would argue sometimes in severe ORPD, to release the disc. I don't tend to do that, but that's certainly debatable. The bottom line is, whatever you need to do to make that malaligned regional sagittal plane deformation more correctable will be important, along with, again, then differential rod contour and bringing the spine, back into more posteromedial realignment to recreate that sagittal regional kyphosis. Whereas then with a higher grade AVR, it would seem logical that we're going to need more apical derotational methods to derotate the torsional kind of rotational malalignment of the vertebrae around the apex. So that's the implication. Obviously, we have to prove that, but that would be the logical implication of correction strategies. And hopefully at some point we'll have a much more defined correction strategy plan that has been proven, with data, that if we have a certain ORPD / AVR combination for thoracic, lumbar, proximal thoracic curves, that this would be the recommended treatments for those regions to optimize the three-dimensional correction. We're not there yet because we don't have data pre and post-op to prove one technique is superior to the other. But ultimately, with data, Carl-Erik, we should be able to have that, right? I mean, in probably fairly short time, right, Carl-Erik, when we can analyze pre and post-op cases and understand what techniques were utilized in surgery to correct the deformity.
Yeah, Professor Aubin, you want to add?
Yeah, sure. I think it's a first step. So we have a classification, we have descriptors, we have now a language to communicate. And in the paper that was published last week, we have shown also that they are not correlated. So we have, let's say, and the two cases that Dr. Lenke presented, there was a large ORPD with a small rotation, and we have shown in our large database of cases that you can have a 1S or 1M or 1S, 1L or 3S or 3. So they are all combinations are possible. So there's no correlation. That means that we will need to learn. If it's a 1L, it will be different than a 3S. Then now, if we are just looking at the Cobb angles, we have a certain strategy. But if we have more tools or more words to describe the three-dimensional anatomy, then I think the next step will be to better understand how they are interacting and develop strategies that will be informed by these new 3D indices or descriptors. And having a common language, then it will be able to communicate and exchange and define criteria, surgical criteria, and techniques according to the different presentation of this.
We'll request Dr. Gadegone, who's practicing currently in rural India and doing a lot of complex deformity. He's well trained in deformity in Australia and Korea and trained with Dr. Basu. Dr. Gadegone, up to you.
Yeah, so I wanted to ask, has there been a discussion as to the current classification has been studied into retrospectively of few cases who have had coronal decompensation, say in cases of selective thoracic or selective lumbar fusions? And do you see these kind of new data and these new modifiers being considered into future recommendations, which will allow us to further refine cases whom we can go ahead with selective thoracic fusions or lumbar fusions?
That's the ultimate goal, obviously, is not only help with regional correction strategies, but also just global scoliosis approaches, right? This may further refine which curves get fused or which don't get fused, i.e., selective thoracic, selective lumbar fusions versus double major, triple major fusions. So yeah, basically, based on data that will be collected, I think that's ultimately the goal is to further refine going from 2D to 3D, what not only the correction strategies will be, but really even before that, which curves need to be treated, right? And with non-fusion technologies becoming, hopefully more forefront in the future, how those will be impacted by this new classification analysis as well. So I think, it's only going to further give us more data to more precisely treat our patients, right? We're not there yet, and we'll definitely need data pre and post-op and different strategies to be evaluated. But I would say in 5 to 10 years, we're going to be at a lot different spot in classification, leading to more appropriate treatment to better outcomes. It's going to take time, but I think this is going to definitely allow us to ultimately end up with kind of best treatment paradigms for our patients with scoliosis.
And would it be correct to say that this particular 3D classification analysis can only be done if you have a EOS system or a standing like 3D imaging system?
No, the way it was designed was to be able to use any X-ray system. Any means not only EOS, but all other systems. So we have developed algorithms that enable to do self-calibration of the imaging system, which enable to rebuild a 3D model from any pair of X-rays. So that, this is an important component because in many centers, they don't have access to technology. So we try to have a solution that enable to have not only have access to the 3D, but also the measurement where we can control also the impact of inaccuracies related to image quality and let's say differences in ways that images are acquired. So our algorithms are robust, and this is something we will publish in the coming months and this is part of the effort of the 3D task force to not only have a classification, but also ways to use it.
Yeah.
Thank you.
Just to add on to the question, like we have been asked by a lot of people in audience, how exactly it will work. The software, we are aware that the software will be, we have to upload in the system, and the X-rays will be in the packs or the digicam, and it will analyze and give us help us in classifying that. So if you could illustrate, Professor Lenke and Professor Aubin, if you could tell us how it will eventually work, either some part of the Africa or some part of Australia or North America, how it's gonna implement the software.
So the solution we are developing will be connected to. There will be different ways to use it. So, but the one of the embodiment will be to be directly connected to PACS and be able to use the existing images to automatically do the 3D reconstruction, measurements, and classification and return it. So this is how we plan to do it. There are still technological challenge to do this. We are working on this now. It's complex again, but this is part of our goals. Okay, the goal is to make it available. So this is what we are working on. It will take some time, but we are progressing. So we demonstrate the feasibility, but now it's how we translate a lab setting environment to something that could reflect many different practices and health systems and regulatory specification and so on. So we are working on this, but really the plan, and this is why also we are working under the auspices of the SRS, is to also have a clear vision on how it will be deployed in the longer term to make it available to the SRS members. So maybe Larry, if you want to comment or complete.
Give credit to Carlo, Eric. This is a big part of this process, and without his and his lab's expertise, we would not be able to be at this point, or really finalize this to that this will be available to any 2D X-ray system in the world. That's the goal. But as far as what our initial efforts are, really is to get this classification system and the software involved to create it as part of every SRS member's clinical space. So that's our goal. The SRS is focused on that as well, and we hopefully our industry partners will help us get there as well. This is going to be a combined effort from many different parties, but that is the goal, and I think it's definitely a realistic goal. And the SRS, I think that's why we wanted to partner with the SRS from the beginning on this effort, because ultimately that this is going to be an SRS kind of product, and we're just proud to be a part of this effort and hopefully lead to just better scoliosis care around the world. That's our ultimate goal.
Great. So a few questions from the audiences. They're saying we will be able to classify the shoulder imbalance or the big rib hump or the rib deformities with it, or how it's gonna be? The shoulder imbalance, pelvic obliquities, rib deformities, the clinical appearance, will it be included? How it's gonna be?
Well, obviously that's not part of the classification system now. I mean, there certainly will be other features of scoliosis that will need to be quantified, and whether they formally become part of this system is yet to be determined. As was mentioned earlier, we have our hands full just in getting the global scoliosis community educated and up on this new additional system to the 2D, going from 2D to 3D. I think we don't want to bite off too much right now. I think this is going to be plenty, as people have expressed. It's complicated, so let's focus on getting everyone understanding these new 3D parameters, integrating these parameters ultimately into their clinical practice, and then other features of scoliosis that become that we know are important. Obviously, will either not necessarily have to be part of the classification, right? Because we don't want a classification system that has 50 components. That's not really practical. So, but again, taking care of a scoliosis patient is complicated, right? I mean, there's lots of features, and this is talking about adolescents. Once we go to adults, it gets even more complicated, right? But let's focus now on this 2D to 3D transition. Again, we were thinking of trying to classify scoliosis with the initial 2D system 25, 30 years ago, but we were nowhere near having the ability to do that. So, I'm actually shocked it's been taking us that long to get to where we are today, but there's a reason for that. It's complicated, and that's not only complicated in the understanding, but complicated in the process of processing and getting us the images we need to be able to classify. And obviously, Carol Eric's worked his whole career to do this. I mean, this is his lifetime project, so I give him credit for that, because it's one thing to understand, it's another thing to implement it, in real time. That's what we're trying to do, and it's not easy. So let's focus on these parameters. The other parameters are obviously important: rib hump and deviation from midline, and other factors that pulmonary function limitations and chest wall deformities. That's all part of scoliosis, but I don't think that will ever be part of this classification system personally. I think because I think that'll be too complex. But who knows? I mean, let's just see how this evolves over time.
Professor Aubin, you have to comment on this?
I think Dr. Lenke said it all. I think having other measurement doesn't mean this is complementary. So, like, classification would provide a certain number of ways to handle this, but the other measurements are also important. There are so many measurements on the spine, so we are not omitting the other. We are just saying that it's complementary to the other. So the measure of the balance, the measure of the shoulder unbalance, and so on. These are additional information, but having a classification that will integrate everything, I think that it will be difficult. I think maybe there will be other ways to handle this. Maybe AI would be another way to integrate all of this. This is in addition to this, but I think today we are just we are building something. We are adding one additional level to the existing system. So this will enable to keep what the current understanding of classification to something that will add another dimension to it, so the transverse plane dimension. And we acknowledge it's a simplification, that we are not integrating everything, but we're not saying it's replacing all other measurements. We're just saying it's in addition to the others. So I think it's how we have to see this.
We'll take last question from the audience. The last question asked about it took like from the last GPGS classification or Lenke's classification by Professor Lenke et al. In 2002. It took about a decade or more to get implemented and translated into the clinical practice. And with this new 3D classification just in 2025, 2026, what future will look for it? Like it will take a little bit of time. What's the future for it?
Maybe Larry.
From a clinician perspective, I think it's not, once you understand the principles of what ORPD and ABR are depicting, I think it's going to be very quick for surgeons to understand this, because we've been correcting these parameters for quite some time now. We just didn't have a way of classifying and communicating about them. Also then to show pre to post-op how we're changing them. So I think the transition is going to be personally quite quick, honestly, with this, because we have been already correcting these things in 3D. We just didn't communicate them very well, and we didn't document how we were changing them very well. But we're going to be able to do that, once we get this classification system and used around the world very quickly. So, Carlo, I from a clinician's perspective, I'm very optimistic. The transition is going to be very quick. What do you think?
I'm on the same line with you. I think the challenge today will be also that many others are asking, could we apply it to non-op cases? Could we apply it to adult cases? So I think the same concept could be directly applied, but I think we need to be careful. I think the first step was to complete this one for AIS. And I think the perspective is very great, because I think with the same concept we can also use it for managing deformity at various it could be smaller curves or larger curves, not only surgical cases. So I think the future is great. Again, there are still important challenges, because we can have the classification, but if it is not available to the surgeon, it will not be used. So I think there are several still challenges to make it available to others, make it to validate it, to have something that could be trusted, reliable, and available to the people and accessible when it is needed. So not 1 month after, because it has to go through a measurement centers or so on. So I think there are several challenges, but the future looks great. And again, we'd like to thank the SRS to be there to make it happen. They are very interested in, and motivated to, and they are, and the task force members are enriching this discussion. So it's not just me and Dr. Lenke, it's all the other members that are contributing. And truly this is reflected in what we have today. It's an integration of knowledge and experience, and we look forward to it.
Thank you so much. The topic is so vast that we divided into 2 parts. In part 2, we will have Professor Aubin and Professor Newton discussing in much more detail, and in a couple of weeks we will have Professor Aubin and Professor Newton discussing the later part of it. We thank our esteemed faculty, Professor Lenke, Professor Aubin, our panelists, Carlo, Iorio, Theresa, Josephine, as well as Piyush. We also thank the OrthoTV studio, Maharishi Rishi, Poonam, our mentors, Dr. Ashok, Shyam, and Dr. Neeraj, Bijlani. Thank you to all the viewers across the globe who keep supporting and encouraging us and keep asking the difficult questions. Thank you very much.
Good job, Raj. Thank you, everyone.
Thank you very much, Raj.
Thank you.
Thank you, everyone.
Thank you so much.
We can stop recording, mate.
Thank
Marcia?
you.
Okay.
Good night.
Thank you again, Raj, and
Thank
all
you.
others. I'll be in touch. Okay,
Thank you.
bye-bye now.
Bye-bye.
Thank you, Dr. Aubin.
Bye-bye.
Thank you.
Thank you.
Thanks, bro.
Thanks, bro. See you. Take care.
Great to see you.
Great to see you too.
Bye, mate.
Maharishi,
Yeah.
can you stop live recording? Like stop streaming? Yeah. महर्षि कैसा था?